Thank you very much. And I'm privileged to present to you the first valve medical XEMED TAVR system, the first in human case that was done in Israel. These are my disclosures. And how do I go back? Okay. Can we go back to the first slide? I'm sorry. Here. Thank you. So this is the XEMED modular valve that you can see the components, the two components on the left side. You see the valve module. On the right side, you see the anchor module. In the middle, you see the assembled device. It's a transfemoral implantation with 12 French OD and 9 French to come in the very near future. This is the procedure pre-docking. You can see it's a very flexible device. You introduce the tip into the left ventricle, and then you deploy the anchor module above the annulus with a functioning aortic valve. And then you see the self-assembling valve module that deploys in the ascending aorta. You see the pusher being advanced, and then the valve module is pushed down into the anchor module and locked. Then we see the implant, that is the valve module, and simply by pushing the device forward, it deploys in the annulus into the correct position, and then the wires are being pulled back. So the delivery system profile in perspective, you can see here in the lower part the XEMED compared to other delivery catheters. You can see the difference, a very flexible, thin system. So the first patient that was being done by Ran Kornowski and his team in the Rabin Medical Center in Israel. And here you see the patient was an 88-year-old patient, was very sick actually, several consecutive admissions due to pulmonary congestions. The CT TAVR workup showed that this patient was not really suited for either surgical or for TAVR implants in any axis. It was just not possible, so the team decided to do a BAV to bridge this. This is the patient's anatomy, and you can see on the right side extremely difficult bilateral iliac femoral anatomy. The axis is shown here, severe peripheral valve disease. You can see also here the stenotic part in the common iliac. The 12 French sheath was not being able to advance. The team used a cutting balloon, and then the sheath was going forward. The valve delivery is shown here. You can appreciate very flexible delivery catheter, thin delivery catheter, as shown in the animation. The wire was in place, the pigtail and the non-coronary cusp as usual. And then you can see the upper frame deployment, which is the anchor module. On the right side, you can see above the functioning aortic valve, the module is being deployed. And then the pre-docking, as shown also before on the left side, you see the valve module that self-assembles in the ascending aorta and then being pushed down with a pusher into the anchor module. And then you see the implant with the assembled device pushed simply forward as the valve is deployed with a very good initial result, as you can see here with the assembled device. Hemodynamics are excellent, as you can see on the right side, before implant on the left and after implant on the right side. No leak, good diastolic pressure, the dichrotic notch, and obviously no gradient. The TE during the procedure shows the device in place, good position with regards to the mitral valve and to the annulus. A little bit of a central leak. Remember, this is the wire that's still in place. And the TE at discharge shows good position in the valve, no leak. And we're very happy with this particular device. So in summary, an ultra-low profile, true 12 French OD TAVR system. It is a folded valve design. The valve's not crimped. 3D one-piece valve leaflet construction with bovine pericardium. Two-component hydrogel coating on the frame to reduce paravalvular regurgitation. As soon as this hydrogel gets in contact with blood, it swells and seals the valve, so there is supposedly no paravalvular regurg. First in human, as I said, was successfully performed by Rand Kornowski at the Robin Medical Center, and coming up in Q4 2022, the 9 French equivalent inline sheath system. With that, I would like to present the team again that did the case. I had the privilege to be there and presenting on their behalf. I thank you for your kind attention.
Question for Eberhard.
Actually, I have 2 questions. Very fascinating design. One is, it seems like once you put the anchoring device in place and before the valve pushes it down, you're basically working off of a wire. I didn't see any catheter that gives it support. Can you ever get the valve portion be canted, and then now you can push it down to get the device to open up? That's question 1. And question 2 is, do you really need calcium? Because it looks like you have a nice anchor with the first frame that you put in. Could this be useful in AI?
So the first question that you're asking is, obviously, time will tell and more devices will tell. So far, the technical part was very convincing. It's the first case. Obviously, we were suppressed, and you can't really look into the future. We are very optimistic, actually. The system proved to be very reliable because we had the first generation design being worked on in São Paulo some years ago, and the team has learned how to overcome these tilting part of the module. So this went very, very smoothly by simply advancing the wires. So it's a very reliable technical system. The second question, about calcification, you're asking the question looking into the forward view. I mean, the 3-piece that's been described before is now, I guess, something that we're all working for in the more modern valves. Time will tell how that's going to be dealt with, but I don't think there's any question that you can do a valve-in-valve like with any other procedure.
Eberhard, according to the lab test, which is going to be or seems to be the radial force of this device?
The what?
The radial.
Radial force.
Radial force?
Oh, the radial force. Well, it's like the usual. No company tells you what the radial forces are. Yeah. So that's obviously proprietary, but it's a very, very good, strong radial force that is being used in calcified aortic stenosis. Numbers I couldn't tell you, but I don't think anybody could tell any radial force of any valve by numbers.
All right, Eberhard, thank you very much. We're going to